we really have a great panel assembled here today. There are two topics. The first one we're going to go through is something that I think is very needed. Infant and toddler myofunctional therapy, a critical need for a novel curriculum. And I just want to preface that by saying, you know, from my personal perspective and that of our institute that we work with, the AOMT, and really the successive boards of the AMS in its short time, about 7 years, we say therapy with an asterisk after it, myofunctional therapy, because really for something to be therapy by a high medical standard, we need to do a validation study. We need to have a couple of boxes that we haven't checked yet. We need to have objective clinical competency accreditation. We need to have licensure, like every other medical profession around the world, or dental or therapy profession. So we're working to that end. I just like to mention that because our society is working to develop those platforms and the science required and the bodies of knowledge required. So, but there is, I think, a critical mass of scientific literature that is demanding more care to be delivered via myofunctional therapy practices. And we've hitting a critical mass. We've got researchers around the world who've taken interest, you know, maybe going from when we first organized the society 7 or 8 years ago, 100 or so papers in PubMed to today, you know, using different variants, maybe over 800, and many more papers in the pipeline. So we've got statements from national societies. I mean, geez, I was asked to go to the Japanese consulate yesterday afternoon to pick up some letters for the government to honor Dr. Yasuo Ito, Dr. Hideharu Abe, and our society. And we've been, you know, nipping at the edges. We helped get the Japanese government to pay for myofunctional therapy last year. So our institute's invited to go to a residency by the Japanese government to help develop more myofunctional therapy for Japan, and particularly as it relates to sleep disorders. So with all of these things and questions, why can't we swim further upstream and look at babies? And what can we do to apply babies, you know, care to help them? Premature babies, intubated babies, really, it's something that, you know, makes me wonder. At our Congress in Rome last year in September, you know, we were looking at these kind of questions, and there's a great team from Mahidol University in Bangkok that looks at pregnancy and sleep apnea and the outcomes on the fetus and you know, the newborn babies. And I think, why couldn't we screen parents who are considering having babies for myofunctional disorders? So if we could just kind of like, we have a very tight schedule. We have, so if we want to just pass it down the microphone, if you guys want to make a statement and a comment, and we'll have a little bit of discussion. And then when we kind of hit a time limit, we'll move on to the next topic, which I think is also very pertinent and critical here. And we have some great people here to contribute. Dr. Zaghi, Dr. Sproit, if you could pull up a chair and come along here and co-moderate this with me. If you, and the second topic is research priorities in frenulum surgery. So we are very far, I think, from a standard of care, and you know, but there's a lot of noise and static, and there's a lot of exciting new work that's being done. So anyway, if we could, you know, kind of like pass it along. So Dr. Sproit, as you may know, I hope you guys all had a chance to read the bios in this late-breaking symposium. Dr. Sproit, I think, is a giant in sleep, neurology, pediatric medicine. She's someone who I've seen all of her papers and her presentations over 6 or 7 years, following her and engaging with her little bit by little bit more. She's someone who connects the dots. And myofunctional therapy is something that really requires that kind of precision medicine approach, you know, connecting the dots, because it's not owned by anyone's specialty. Although some people who have specialization would like to think that, it's not owned by any one area of medicine. Hopefully, it'll grow up from being an area that's emerging to a field, and it can be something that can be shared across disciplines. Thank you.
So, hi. Thank you, Mark, for the invitation, and hi, everybody. So, Mark already gave an introduction. So, from what I've seen so far, I can only concur that, and I see an infant there at the back of the room. So the pathway to the world of a young child is sensory motor function. So if you want a child to develop, to have a good neurodevelopment and exploration of the world around it, everything goes through the mouth. So I'm happy to see that you're moving forward in that direction. So, and I'm happy to help out. So thank you for the invitation.
I'm Katrina Rogers, and I'm a speech and language therapist in the UK with specialism in treating and managing dysphagia and children who have respiratory illness associated with that. And I think that 25% of my caseload have issues associated with tongue tie. In the UK, disappointingly, my requests to have that managed and treated are not looked at. And in the UK, we have very poor uptake on breastfeeding. I'm not sure of the statistics, but the system doesn't really look closely at tongue tie. Mums get held up, and so they resort to bottle feeding. So I think that from the conference that I've been here for the full 3 days, I think we need to be looking at supporting functional health and through looking very closely at tongue position and tongue function and supporting breastfeeding.
My name is Michelle Diemanuele. I'm an occupational therapist in Cincinnati, Ohio, and I specialize in the pre-crawling baby. I'm very excited about the myofunctional health for infants and the impact that optimal oral rest posture and parent education and neurodevelopmental input for cranial nerve function can have on babies.
So, we do a lot of tongue ties, but like Michelle's saying, it's really critical for the babies. When Molly was born, I asked Michelle, because she's my go-to for this kind of stuff, said, what should I do? Molly's tongue is down. She said, just hold it up for her. So she's the sleeping tongue posture hold. You can physically just push on the baby's tongue, massage it like this, and you can open their mouth and it's up. And you can check it and see. And we did that, and then she was mouth breathing a lot for the first month or so. She said, just keep closed. So I just kept closing her mouth. So you're basically doing the myofunctional therapy for them. Your tongue up, like you said, and if you're closing their lips for them. And then after about a month, she just did it. So now she automatically does that now. And if I ever check her, her tongue is up. So it's really helpful for babies. Good job, Michelle. She's the brains behind this thing. But then just in kids too, they can do a lot more things than you think they can. Like an 18-month-old, a 2-year-old, they like to imitate. Even Molly, if I stick my tongue, she's 8 months old. If I stick my tongue out at her, she sticks her tongue out too. And you can have them do waggle spot, you can have them do gumball, you can have them do paint the roof. Suction hole's a little bit harder, but there's lots that you can have them do. Just because they're 2 years old does not preclude them from myofunctional therapy, certainly. And obviously a tongue tie release, the sooner the better. Ideally in infancy. We did our daughter Molly at 2 days old, but in general, the sooner the better. So don't wait till they're 5 and can cooperate.
Hello everyone, my name is Sarush Zagi, ENT and sleep apnea surgeon. I think it's terrific that we're talking about these issues, and totally agree and resonate with the fact that we need to have better curriculums. I personally specialize in children above 3 years of age, but you know that it was there even before they present, and just listening to these parents and the videos they bring from the infancy, the signs were there. It's just so difficult to intervene when it's a tongue tie. Like Dr. Baxter said, it's wonderful if you can provide that treatment, but in a lot of cases, there's something else going on. And to that, we look to our occupational therapists and physical therapists, and it's really great to have us all listening to each other and sharing these pearls of wisdom. I'm personally going to, try some of these things that I've learned from you guys in terms of moving the neck and engaging the face and the floor of the mouth and the tongue to see what works. And it's really by just trying these things that we can really advance the field. So it's wonderful that we have this forum here at the AMS where we can practice in our own communities and come back to share experiences, because that's the way we're going to learn. So thank you all.
Hi, my name is Yu Wing Chu. I'm a general dentist from Singapore. I have special interest into treating patients with TMD and sleep problem. And I think one of the problems is that I'm seeing the control group, right? The babies that didn't get tongue tie released, they grow up and they end up, in my chair with this kind of issues. So we need to move forward and move back in time, even, right, for them. We can't treat that patient and just change, but can we do it for those that are coming into the world? So I think looking at this issue, we have to look at how nature was like last time, right? We were all breastfed before 1950s. And everything after that, things change because we need to grow the economy. But that's like how we destroy the earth, because we need to, get more land, cut more trees. We need to re-look back, and I think as a human race, we need to keep surviving. And if we forget this part, I think it's a big problem. And I think not only just on the clinical side, I think I would like to even shout out to Mary, right? So even for manufacturers, they are coming up with devices like the smaller ones, my own baby munchie, right? Yeah. So that even my friend, he has a 2-year-old sucking thumb, 2 fingers, sorry. And the moment we give him a baby munchie, he's now chewing around and he's walking around with that. So we can change things around with some passive OMT, like what Dr. Fellows have been talking about as well. All right, thank you.
As I was introduced, I'm a pediatric surgeon, and when I graduated from the medical school, the snipping of tongue tie was very common. But after that, the Japanese Society of Pediatrics made a statement that it's not necessary, it's useless. After that, the tongue tie release are not done. Many pediatricians think it's not necessary, so that patients do not come to pediatric surgery. But so I was more involved in a major surgery of newborn babies and congenital surgery, congenital anomaly surgery. But about 10 years ago, I retired from academic position and start working with pediatric group. So I learned pediatrics also, working with pediatricians. And I noticed how different our thinking are. They are all against to my operation. So I have to convince them that it is effective. I mean, the tongue tie release is effective. Mm-hmm. So that's my starting point of the study. So it's only 10 years ago. So I've learned a lot from this society. And all of you are my teachers. And I published 2 papers about breastfeeding and speech problems, 2014. Some of you may have read it already, but still I'm continue studying to convince all the Japanese society that it is effective, but it's on my way yet. So what can I do for the rest of my life? Well,
it's beautiful. Stand up and say it's not the moms, it's the baby.
Well, did the presentation at the Society of Newborns, Infants, and the lactation consultant, professor of pediatrics, said there's no meaning. If you cut the tongue tie, after 5 days birth. But I was showing that it is effective. And the other one, the comment was, why do you evaluate mother? Because I I said the breast pain, also nipple pain improves after that. But they said, why do you evaluate mother side too? So that's the now a common sense of Japanese pediatricians and even professors of pediatrics. It's a shame.
It is. It is.
Okay.
今日本は世界一介護が多いんです。
This is Dr. Abe. He's a Japanese dentist. And in Japan, we have so many people who needs help.
それで日本の政府は2つの政策を出しました。
And Japanese government has two plans.
保険の制度に、65歳以上が口腔機能低下症
Focusing on people over 65 years old for malfunction, oral malfunction.
0歳から15歳までを、口腔機能発達不全症
And for oral dysfunction for people, children between 0 to 10 years old.
この2つの病名が保険に入ったんです。
And those two diagnoses were included in the health systems.
日本はこのままでは子供が生まれない、介護が増えるで国が潰れてしまいます。
At this rate, Japan has less children and more older generation of people.
このようにこの分野は国が取り組み始めると急速にこう広がってきます。
However, this governmental involvement help us to proceed with this system that we are passionate about.
そのように国を動かすためにもこのようなグループを作るということは非常に重要だと思います。
So to move the government, it is very important to form this kind of society that we have now.
世界中から集まった皆さんがこうやってネットワークを組むということは本当に世界を変えるような大きな力を持つと思います。
Networking with people around the world that like you guys really moves the world and it changed the world.
Thank you.
I'm working a little bit. I've got my baby toe in myofunctional therapy. I'm working with Joy Muller. And we think that hypoxia may play a role in the disorder I've spent a good many years investigating, which is the Restless Leg Syndrome. And so we haven't actually done a study yet. I've sent some patients to Joy who've done myofunctional therapy in my patients with Restless Leg Syndrome. We don't quite know what the results are yet. We're also going to look at a cohort of children. And there is actually some really good evidence now that the restless leg syndrome, just to familiarize yourself for those who don't know it, the patients have an urge to move the legs usually because there's some leg discomfort. They do move the legs. They get some relief by activity. It tends to be worse at night and also worse at rest when you're lying or sitting. And it's a large disorder. It affects about 2.5% of the such population in a serious way that they need treatment. But there's been a lot of research in the last 10 or 15 years showing a connection between the restless leg syndrome and cardiovascular disease, stroke, and hypertension. And some of the studies, for example, that we published 2 MRI studies, one in 2016, one in 2017, and they both showed that an MRI scan, the RLS patients have more microvascular disease, which is a precursor to stroke, than the controls. And if we started out from the point of view of entering the patients with restless leg syndrome, or the point of view of entering them from the point of view of periodic limb movements in sleep, which are involuntary kicking movements that occur during sleep, which can occur with RLS or without it, they also show more microvascular disease. And in a study that we just presented 2 weeks ago at the World Sleep Meeting, which is an autopsy study of RLS patients and controls, that confirms that the RLS patients have more microvascular disease than the controls. So obviously the question arises whether hypoxia might be causing a role in the increased cardiovascular disease and stroke and so forth and so on. And thus our study, in an attempt to see if myofunctional therapy helps the restless leg syndrome. So that is sort of why I'm here. I'm local, but I was invited because of with a study that we're hopefully going to start, and this interesting connection. I wanted to ask you a couple of questions actually about you. Yeah, no, you. I was trained as him. Yeah. Sorry about that. I like to talk to you too. Maybe later. You sound very interesting. So before, as a neurologist, before I was trained in sleep disorders, I was trained in movement disorders. And you presented a case of Tourette Syndrome. And one of the things that we know about Tourette Syndrome is that the movements are suppressible by mental activity, which of course is a type of sensory input, and you talk very interestingly about the connections between sensory input and motor output. And in that sense, we can look at these correction of the Tourette syndrome as maybe one of a type of sensory input to the syndrome that will allow it to be suppressible, because one of the things that does characterize Tourette's is its suppressibility. I was also very interested in your patient that had the distorted posture, because of course it could be a neuromuscular disorder. I don't know, an orthopedic problem. We don't know. But another thing that looks very much like this is dystonia, which is a movement disorder. And one of the things we also know about dystonia is it's very sensitive to sensory tricks. For example, if a patient has torticollis like this, if they just simply touch the cheek, they can improve the torticollis. So really bringing the tongue up to the roof of the mouth is another sensory input. So I thought it was very interesting to look at the bringing the tongue up in terms of its broader categorization as a sensory input, in the context of the fact that other sensory inputs can do that. So I was very interested in that.
I think maybe
wait. Pass the mic.
From a very simplistic look at it from a dentist point of view. So look at the tongue when it goes up, right? Trigeminal nucleus actually takes a lot of information from the head and neck area, and a trigeminal nucleus is next to the vestibular nucleus. So when you play a basketball, right, your head is bobbing all around, and yet you still can balance yourself. So that the pathway of communication has to be very, very clean and clear. So if you don't put your tongue in the right place, your head is off axis, and then your body will just do the wrong kind of compensation. And once you put it in, trigeminal nucleus send the right signal to vestibular, the whole body works together in a smooth way.
So you're saying then that this idea of putting the tongue up to the roof of the mouth can help your performance as an athlete?
We can see immediate improvement.
Oh, good. I'm a very bad tennis player, but I take lessons. I will try to do that the next time I take a tennis lesson.
There's a sports institute that supports the Australian Olympic team that has actually reached out to us about exploring training for their athletes.
As they should.
So I just want to say something about Dr. Walters. He's also known as like one of the fathers of the area of sleep medicine, particularly RLS and pediatrics. And he's such a great and passionate advocate for science and truth and research and helping patients, whatever he can do. We've been on some adventures together, and he's been at times a very kind and generous mentor. He helped me run a panel discussion right here. We had a focus group assembled right here in Nashville about 5 years ago. And we did it with the National Black Association of Speech, Language, and Hearing to explore what we need to do to move myofunctional therapy. Like, we know that there's something there. Like, for instance, how we can engage the speech pathologist. What do we need to look at? And one of the really interesting takeaways was that, you know, you looked at all of the suffering patients present with, not just infants, but if they could be intervened with at infancy, maybe they wouldn't be patients having had 3 orthodontic relapses or having been a candidate for, you know, MMA surgery, or, you know, wind up, you know, having been not using the CPAP in their closet for so many years. And so perhaps you could say something about the journey that you undertook, I think way back in the 1980s, to help a patient organization develop, and how that impacted, because you talk about 2.5% of the population. You know, we don't have the prevalence knowledge or data, and we've been scratching our heads with some groups at Stanford and Harvard and elsewhere. How can we come up with a prevalence number of orofacial myofunctional disorders in the general population, or just a subset that could be, you know, comorbid with sleep disordered breathing? And, you know, I mean, for us, you know, there's vast speculation. People start seeing myofunctional disorders in a lot of places, but we think there's a significant portion of the population who could benefit not just from treatment, but early intervention.
The patient organization sort of came about as a result of the fact that I was really sort of one of the first people to do much research in restless leg syndrome. And there was a nascent patient group of about 6 people that were letter writing each other in the early 1990s, and they found me and they asked for my help. And so at that point I was in communication with them, and they founded the patient organization called the Restless Leg Syndrome Foundation. And one of the things I suggested to them was that they have a medical advisory board, because that would get strength and power to the organization and legitimacy. They were putting out a newsletter, and they needed I said, you need a medical advisory board who'll read the newsletter, so it'll give it legitimacy. So they said, well, how do we find one? And I said, I guess that has to come to me. So I went to all of the other handful of people that were doing research in the restless leg syndrome. Now there are thousands of researchers. It's like your field is exploding, but it was at the beginning. And so I went out and recruited the first medical advisory board, and that turned out to be really important to the patient organization. And now it has, like 25 years later, and they're still going strong. They've got 70 support organizations all across the United States. They have a medical advisory board and a scientific advisory board. And I think that's really important in pushing the science forward. It can be so powerful. They have a research grants program, and they always try to get articles about restless leg syndrome out in the news media. And the patient support organization, this group itself, can be powerful politically too. In addition, we also formed another organization, which was the International Restless Leg Syndrome Study Group, which was by and for physicians. So there are 2 parallel organizations, the scientists and the physicians that were doing research jointly, as well as the patient group. And so I would say, you know, starting maybe to have patient groups and have support groups across the country in some sort of way is I think one of the ways. It was certainly helped for our disorder, and you know, the rest is history. Now there are lots of researchers in RLS, and I would just strongly suggest that might be a way forward.
Thank you. You may all know, I mean, there's, you know, therapeutics, you know, pharmaceuticals, you know, all kinds of approaches of investigation, and people looking at restless leg syndrome. And whereas before, you know, patients were told that they're crazy. Yeah. And, you know, we have similar kind of things with patients being told that they're crazy because they're relapsed orthodontics and the rake didn't work, or, you know, the patients, you know, who've been diagnosed with ADHD and they're told that they're suffering from so many things, when, like Stephen Sheldon might say at a meeting, you know, the vast majority are orofacial myofunctional disorders that resulted in sleep disorders. And, we've got a long way to go, but we've got great, mentors and friends who can show us pathways forward. And I think a patient-based organization, because patients are angry. The patients that come in and had, 2 relapse orthodontic surgeries or relapse orthodontics or who knows what, they've suffered. And so I think that's something that we have been exploring since, with that panel discussion way back in Nashville 5 years ago. But even more, to create a foundation for that, you probably remember at the World Sleep Congress just over 2 weeks ago, we announced the formation of the International Research Network for Orofacial Myofunctional Therapy. So we have a foundation called ARI, which is an acronym for the Airway Research Institute, that's looking to raise, we're applying for millions of euros to just begin the planning phases. So we're really excited, and thank you for your time.